First degree heart block. Definition: PR interval is more than 200 milliseconds, 5 small squares. There is delay, without interruption, in conduction from atria to ventricles. Marked: first degree heart block is present if PR interval greater 300 milliseconds. Clinical significance. As an isolated finding, this is a benign entity that does not cause hemodynamic instability. No specific treatment is required. Marked: first degree heart block. PR interval greater than 300 milliseconds. P waves are buried in the preceding T wave. Sinus bradycardia with first degree AV block. PR interval greater than 300 milliseconds. PR interval 260 milliseconds. Normal sinus rhythm with first degree AV block. Definition of Mobitz eye block, Wenck-Bach phenomenon. Progressive prolongation of the PR interval culminating in a non-conducted P wave. PR interval is longest immediately before dropped beat. PR interval is shortest immediately after dropped beat. Other features. The PP interval remains relatively constant. The greatest increase in PR interval duration is typically between the first and second beats of the cycle. The RR interval progressively shortens with each beat of the cycle. The Wenck-Bach pattern tends to repeat in PQRS groups with ratios of 3:2, 4:3 or 5:4. Mechanism. Mobitz 1 is usually due to reversible conduction block at the level of the AV node. Malfunctioning AV nodal cells tend to progressively fatigue until they fail to conduct an impulse. This is different to cells of the His-Purkinje system, which tend to fail suddenly and unexpectedly, i.e. producing a Mobitz 2 block. Clinical significance. Mobitz 1 is usually a benign rhythm, causing minimal hemodynamic disturbance and with low risk of progression to third-degree heart block. Asymptomatic patients do not require treatment. Symptomatic patients usually respond to atropine. Permanent pacing is rarely required. Mobitz 1 AV block. Progressive prolongation of PR interval, with a subsequent non-conducted P wave. Repeating 5:4 conduction ratio of P waves to QRS complexes. Relatively constant PP interval despite irregularity of QRS complexes. The first clue to the presence of Mobitz 1 AV block on this ECG is the way the QRS complexes cluster into groups, separated by short pauses. This phenomenon usually represents second-degree AV block or non-conducted packs, occasionally SA exit block. Mobitz 1 AV block. QRS complexes clustered in groups, separated by non-conducted P waves. The P QRS conduction ratio varies from 5:4 to 6:5. Note the difference in PR interval between the first and last QRS complex of each group. Mobitz 1 AV block associated with inferior STEMI and RV infarction. Mobitz 1 in a patient with atrial pacing following mitral valve surgery. Small atrial pacing spikes precede the QRS complexes. The interval between the pacing spikes increases progressively until there is a non-conducted pacing spike. Definition of Mobitz 2 block, Hay block. A form of second-degree AV block in which there is intermittent non-conducted P waves without progressive prolongation of the PR interval. Arrows indicate dropped QRS complexes, that is, non-conducted P waves. Other features. The PR interval in the conducted beats remains constant. The P waves march through at a constant rate. The RR interval surrounding the dropped beats is an exact multiple of the preceding RR interval, e.g. double the preceding RR interval for a single dropped beat, triple for two dropped beats, etc. Mobitz type 2 rhythm strip demonstrating non-conducted P waves. Mobitz 2 Hay block. AV block. Second degree, fixed ratio, blocks. Fixed ratio AV blocks. Second degree heart block with a fixed ratio of P waves. QRS complexes, e.g. 21, 31, 41. Fixed ratio blocks can be the result of either Mobitz 1 or Mobitz 2 conduction. ECG examples of fixed ratio AV blocks 2-1 block. Non-conducted P waves are superimposed on the end of each T wave. The atrial rate is approximately 75 bpm. The ventricular rate is approximately 38 bpm. The atrial rate, arrows, is approximately 90 bpm. The ventricular rate is approximately 30 btw per minute. Note how every third P wave is almost entirely concealed within the T wave. High-grade AV block, 4:1 conduction ratio. Atrial rate is approximately 140 beats per min. Ventricular rate is approximately 35 beats per minute. AV block, third degree, complete heart block. ECG features of complete heart block. Severe bradycardia due to absence of AV conduction. The ECG demonstrates complete AV dissociation with independent atrial and ventricular rates. Complete heart block. There is AV dissociation with the atrial rate nearly 100 bpm, independent of the ventricular rate nearly 40 bpm. In complete heart block, there is complete absence of AV conduction, with none of the supraventricular impulses conducted to the ventricles. The perfusing rhythm is maintained by junctional or ventricular escape rhythm. Alternatively, the patient may suffer ventricular standstill leading to syncope, if self-terminating, or sudden cardiac death, if prolonged. Complete heart block. Atrial rate is nearly 85 beats per minute. Ventricular rate is nearly 38 beats per minute. None of the atrial impulses appear to be conducted to the ventricles. Rhythm is maintained by a junctional escape rhythm. Marked inferior ST elevation indicates that the cause is an inferior STEMI. Complete heart block. Ventricular rate is nearly 27 beats per minute. Atrial rate is nearly 60 beats per minute. None of the atrial impulses appear to be conducted to the ventricles. There is a slow ventricular escape rhythm. Complete heart block. Atrial rate 100 bpm. Ventricular rate only 15 bpm. This patient needs urgent treatment with atropine, isoprenaline and pacing. Complete heart block with isorhythmic AV dissociation, long rhythm strip.